So first of all, thank you for joining everyone this evening. My name is Molly and I'll be the moderator for tonight. I'm a pharmacist at Whole Health Pharmacy Partners. We're an independent pharmacy banner with around 140 locations across Canada. If anyone is interested in finding more out about Whole Health, please don't hesitate to reach out after the session. So we're very pleased this evening to present the second session of our Cancer Care in the Community series with Extend Pharmacy. Extend is a specialty cancer care pharmacy based in Ottawa. We're really proud to say one of our pharmacies in our network. The vision for this webinar series is really to provide guidance and to identify resources to support that generalist pharmacist in the community in managing their oncology patients. So this session will be centered around opioid use for patients with cancer pain, highlighting some of those key considerations and actions and monitoring for pharmacists. Now we have two very special and experienced guests with us this evening, and I'll start off by introducing Dr. Jenny Lau. So Dr. Lau is a medical doctor, and she's the medical director of the Harold and Shirley Lederman Palliative Care Centre in Toronto at Canada's Princess Margaret Cancer Centre. She's a palliative care physician who trained in family medicine at the University of Ottawa and then completed her year of added competence in palliative care at the University of Alberta. Dr. Lau leads numerous local and national projects focused on promoting safer opioid use in the context of life-threatening illnesses. We also have with us Lauren Hutton, who is a pharmacist working with Extend Health Solutions on their external education and initiatives portfolio. She's also the clinical coordinator for oncology pharmacy at Nova Scotia Health in the Central Zone in Halifax, Nova Scotia, where she has a clinic caring for patients with prostate cancer receiving oral anti-cancer therapy. Lauren completed a Bachelor of Science in Pharmacy at Dalhousie University. She completed her hospital residency at the Ottawa Hospital and subsequently went on to complete her Doctor of Pharmacy at the University of Toronto. Lauren has been practicing in oncology for 4 years, and her oncology clinical practice areas have included ambulatory medical oncology at the Ottawa Hospital Cancer Centre, and acute inpatient palliative oncology care, followed by multiple myeloma ambulatory care at the Princess Margaret Cancer Centre. So thank you both for being here with us this evening and developing this amazing presentation. We are very much looking forward to the session. Just so for the audience, so the audience is aware, the slides will be available after the session. And if you have any questions during the session, please post them in the Q&A or in the chat box, and we'll get to them at the end of the session. So without further ado, I'll pass it on and begin the presentation.
Thank you so much, Molly, for that kind introduction. So Lauren and myself do not have any disclosures or conflicts of interest to declare. So for this session, we have several objectives. So these objectives are as follows: to describe the current opioid crisis in Canada, to explain the role of opioids in management of cancer-related pain, to incorporate the World Health Organization guidelines into your pharmaceutical care process for patients receiving opioids for cancer-related pain, to develop a monitoring plan, safety and efficacy for patients receiving opioids for cancer-related pain, and lastly, to summarize pharmacy-sensitive practices that you can implement and champion in your practice settings or institutions. So the first myth that we're going to explore today is that the opioid crisis has been replaced by the COVID-19 pandemic. The COVID-19 pandemic has taken over almost all aspects of our daily lives. Unfortunately, it has not taken over or replaced the opioid crisis. In 2016-2017, both Canada and the USA declared that both countries are experiencing major public health crises related to rising opioid-related deaths. And between January 2016 and September 2020, there were over 19,000 apparent opioid toxicity deaths. On average, here in Canada, there are 16 opioid poisonings that result in hospitalizations each day. When we compare the same 3-month timeframes in 2019 and 2020, what we see is that there has been an over 120% increase in opioid toxicity deaths, from over 700 deaths to over 1,700 deaths in those 3-month timeframes. Most of these deaths have occurred in men between the ages of 20 and 49 years old. And there are a lot of factors that are contributing to this rise in the number of opioid-related deaths. Some examples include limited availability and access to drug-related services, so addictions medicine services, and an increasingly toxic drug supply. The opioid crisis is a result of many complicated factors, and one of the main drivers of the current opioid crisis is fentanyl, and fentanyl analogs are contaminating the counterfeit prescription drug supply. And however, it's important to consider that other factors that are contributing to the opioid crisis include non-medical use of prescription opioids and heroin. This is data from Public Health Ontario that demonstrates that fentanyl is indeed responsible for the majority of opioid-related deaths, approximately 80%. However, I'd like to draw your attention to the other opioids that have been found to directly contribute to opioid-related deaths. These include methadone, hydromorphone, oxycodone, morphine, codeine, and buprenorphine. This graph clearly demonstrates that 20% of the opioid-related deaths are related to prescription opioids. This graph from the Ontario Drug Policy Research Network demonstrates that prescription opioids, these findings related to prescription opioids and opioid-related deaths is really important to keep in mind, because what this graph demonstrates is that prescription opioids are commonly being used to treat pain. So you'll see that though there has been some decrease in the use of prescription opioids, it's still a very common tool, an important tool for management of pain. This is another study from Ontario that demonstrates that prescription opioids are very important tools for management of pain, particularly in cancer care and in palliative care. So what this retrospective population-based cohort study demonstrates is that of all the Ontario residents who are newly initiated on prescription opiates for pain management between April 1st, 2015 and March 31st, 2016, 5.3% of them received opioids for cancer-related pain. And the median daily dose was 38 milligram morphine equivalents, and 32% of these individuals received a daily dose of more than 50 milligrams of morphine equivalents, and they received a median supply of 4 days. And in comparison, 1.2% of these individuals who were newly initiated on prescription opioids received them for palliative care, and the median daily dose was 30 milligrams of morphine equivalents, and 28% received daily doses of more than 50 milligrams of morphine equivalents, and the median days supplied was 5 days, whereas 34.9% received more than 7 days supply. So this brings up a really important question. If prescription opioids are important for management of cancer-related pain, how can we safely prescribe opioids while preventing and minimizing opioid-related harms, especially given the ongoing opioid-related crisis? So our first polling question that we would like you to participate in is whether or not, what do you think? Do you think that prescription opioids do not contribute to the opioid crisis in any form?
Got some good engagement so far. I think we'll keep it open for just a couple more seconds. And I'll end it at this point.
Excellent. So all of you who polled said false, which is fantastic. That means that you are listening and you are engaged during this in this webinar. So thank you so much.
The second myth that we're going to explore today shines a light on the belief among providers and patients that the goal of pain management is to achieve freedom from cancer pain. To bust this myth, we will briefly review the etiology and prevalence of cancer pain, as well as some of the literature contributing to this myth. Pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Types of pain include nociceptive, neuropathic, and mixed. These types of pain would be classified as pain from a somatic cause or source. Many factors specific to cancer contribute to a patient's experience of pain, including but not limited to tumor location and size, and adverse effects from anti-cancer treatments such as surgery, medication, and radiation. These somatic causes of pain may exist independently or in any combination, as many patients with cancer are exposed to several types of anti-cancer treatment. It's important to acknowledge that somatic sources of pain are only one component of the cancer pain experience. In 1982, the World Health Organization brought together experts from fields including anesthesia, neurology, oncology, pharmacology, psychology, and surgery to develop cancer pain management guidelines. These guidelines were finalized in 1986, and they recognize that pain is a subjective experience and its severity is influenced by psychological factors such as depression, anger, and anxiety. They also highlight that the identification of physical and non-physical components of pain is essential for effective total pain management. Given what we know about the etiology of cancer pain, it's not surprising that it is highly prevalent in this patient population. 2/3 of patients with metastatic, advanced, or terminal phase cancer experience pain. Up to 1/3 of the patients who do experience pain are undertreated. Untreated or undertreated cancer pain has significant ramifications for patients and their loved ones, including decreased quality of life, decreased independence, social isolation, and increased acute care use. Effective management of cancer pain is an essential component of providing person-centered care. But what does effective management mean? And what tools do we have in our arsenal to help patients achieve this goal of care? Many of you are likely familiar with the World Health Organization 1986 cancer pain ladder depicted here. This infographic outlines the two key concepts of this set of guidelines. These two concepts are by the clock. Analgesics should be given on a regular basis, titrated to the patient's pain, and gradually increased until the patient is comfortable. And by the ladder. Analgesics should be prescribed in a stepwise approach, with mild pain being managed by non-opioids such as acetaminophen, and severe or unresponsive pain being managed by strong opioids such as hydromorphone, the doses of which can be increased indefinitely. The messaging of these guidelines is that if these concepts are implemented correctly, it's possible to achieve freedom from cancer pain in more than 90% of patients. These guidelines served to strengthen and perpetuate the myth we're here to bust. Thankfully, the 2019 World Health Organization guidelines on the pharmacological and radiotherapeutic management of cancer pain in adults and adolescents are here to help us bust this myth wide open. This updated set of guidelines shifts from two key concepts and a goal of achieving complete resolution of pain with indefinitely increasing doses of strong opioids to a set of 7 guiding principles that focus on supporting patients in defining an acceptable quality of life as the goal of care, and employing a host of pharmacological and non-pharmacological strategies that address both somatic and non-somatic causes of pain to achieve this goal. The first 3 guiding principles focus on the provision of effective and safe cancer pain management. They outline the importance of setting person-specific goals of effective pain management reflective of the individual's defined acceptable quality of life. Furthermore, they emphasize that the benefit of pain relief must be balanced against the risk of opioid-related adverse effects and opioid toxicity that may result in respiratory depression. These guidelines address opioid safety as an aspect of care that must be assured in order to provide effective cancer pain management. This point is of critical importance, as these guidelines, as with the 1986 guidelines, highlight the cornerstone role of opioids in helping patients achieve acceptable relief of their cancer pain. We see that guiding principle 6 builds upon the original 2 key concepts described in the 1986 guidelines. While administration by the clock remains unchanged, emphasis is put on administration of pharmacologic therapy by mouth where feasible, and that the treatment is for the individual with attention to detail. This principle goes further to emphasize the importance of person-centered care, with the correct dose being the dose that relieves the patient's pain to a level acceptable to that patient. Attention to detail should be paid to dosing times, with scheduled doses at both patient wake and sleep times, as well as throughout the day depending on the patient's needs and dosing formulations being used. Guiding Principle 7 serves as a call to action for all providers to integrate cancer pain management into their practices at all stages of the patient's cancer journey. This speaks to the multifactorial nature of cancer pain and its relation to both the disease stage as well as the treatments being received. We all have a very important role to play. Bringing this myth to a close, we have a polling question. What is the most appropriate goal of therapy for a patient receiving opioids for their cancer pain? A, complete resolution of their pain. B, as much control of their pain as they can achieve with a total daily dose of oral morphine equivalent less than or equal to 90 milligrams. C, 50% reduction in their pain based on a visual analog scale. Or D, an acceptable quality of life as defined by the individual patient.
A little bit of a trickier question than poll question 1.
Oh, yes.
We'll just keep it open
on their toes.
Open for about a second or so longer, and then we can take a look at the results.
It's so great to see the participation. That's the biggest thing.
Awesome. Okay, let's end it here.
All right.
And share. So it looks like most people chose option D, acceptable quality of life is defined by the individual patient.
Yes, exactly. And that's really trying to pull out the main key message of the 2019 World Health Organization guidelines, that effective pain management should really be defined by the patient who's being treated. And that's an important conversation for us to have as providers with the patient, so we know how to build our monitoring plan and support them in achieving that goal. Thanks everybody for your participation.
All right. So the third myth that we're going to explore today is one that was actually introduced for the 1986 WHO guidelines. Almost all pain patients are able to stop their opioid medications at the end of their treatment with no long-lasting effects. The 1986 WHO Cancer Pain Relief Guidelines stated that, quote, wide clinical experience has shown that psychological dependence rarely, if ever, occurs in cancer patients receiving these drugs for chronic pain. Though the authors of these guidelines note in fine text that their guidelines really apply to patients with advanced cancer disease with low likelihood of recovery, and that they also noted that there is very limited published information about opioid-related harms and chronic pain at the time of developing their guidelines, this belief that addiction is rare in opioid use has become widely propagated and applied to patients outside of end-of-life care. So for example, in 2018, the Lancet commissioned a report about palliative care and pain relief, and it said, quote, low risk of non-medical use and drug dependence among patients with palliative care. When you look more closely to see where this claim that addiction is rare with opioid use originated from, what you'll note is that the World Health Organization's 1986 guidelines references one paragraph that was published in the New England Journal of Medicine in 1980. This letter was widely cited as evidence that addiction is rare with opioid use. And if you look at this paragraph in more detail, what you'll note is that these were observations by two physicians about the development of addiction among patients that were hospitalized and prescribed opioids. In 2017, a group here in Toronto wrote a letter to the New England Journal of Medicine detailing the findings from the bibliometric analysis of this correspondence from the New England Journal of Medicine's publication in 1980. And what this group in Toronto found was that that original letter was cited over 600 times. And what you'll see is that the peak of these citations happened in the 1990s. And that was around the time of introduction of OxyContin on the market. And of the over 600 citations, 439 of the articles cited this letter as evidence that addiction was rare in patients treated with opioids. Though there continues to be limited knowledge about opioid-related harms in cancer care, now is the time that we have to re-examine our approach to opioid therapy. In the past, it was true that if you had a cancer diagnosis, you are most likely going to have a poor associated prognosis. And the duration of the opioid therapy that you would be provided would be naturally limited by your life expectancy. However, cancer care is changing, where innovations in cancer care are allowing people to live longer and longer with advanced cancers and to survive their cancers. So it's important to keep in mind the wide spectrum of patients with cancer. One emerging population that we should pay particularly close attention to is a group of cancer survivors. And cancer survivors are typically defined as people who have survived at least 3 months beyond their acute diagnosis and active cancer treatment phase. And what we find is that people who survive their cancer are at high risk of being on long-term opioid therapy. So among cancer survivors, this one study found that the reported average prevalence of being on long-term opioid therapy was 24%. And the likelihood of being on long-term opioid therapy was most commonly associated with head and neck cancers, including people who had completed curative surgery for their cancers. This Ontario-based study of cancer survivors found that the cancer survivors received approximately 2 opioid prescriptions per year. And factors associated with opioid use that these authors found was that opioid use before their diagnosis and a pre-existing history of depression and more than 2 years of diabetes. These findings about chronic opioid therapy among patients with a history of cancer are important because from chronic non-cancer pain studies, we know that the risk of developing opioid use disorder increases with higher doses and longer durations of opioid therapy. This correlation was demonstrated in an American study that was published in 2014. So this group examined claims data of approximately 570,000 individuals over the age of 18 who were newly diagnosed with chronic non-cancer pain and had no previous opioid use or opioid use disorder. And what these authors did was that they categorized the individuals based on their average daily dose into low, medium, and high, and also the therapy of their opioid, the duration of their opioid therapy into acute or chronic. And they defined acute as less than 90 days and chronic as more than 90 days. And what they found was that people who were prescribed high dose of opioids, so more than 120 milligram morphine equivalents for chronic duration, so more than 90 days, were at significantly higher risk of developing opioid use disorder. So the prevalence among that group for opioid use disorder was 6.1%. In comparison, people who were prescribed low doses of opioids, so less than 36 morphine equivalents for short durations, so less than 90 days, had only 0.12% likelihood of developing a new opioid use disorder. The American Society of Addiction Medicine defines addiction as a primary chronic neurobiological disease with genetic, psychosocial, and environmental factors that influences its development and manifestations. Addiction is characterized by specific behaviors that include impaired control over drug use, compulsive use, continued use despite harm, and cravings. These behavioral criteria outlined by the American Society of Addiction Medicine manifest as very specific behaviors when people are on opioid therapy for pain management. So for example, that criteria of having impaired control or compulsive use can manifest as frequently calling pharmacies for early renewals or sharing with their prescribers that they've lost their prescriptions or medications and therefore they need new prescriptions to replace the ones that they've lost. The criteria of continued use despite harm due to use may manifest as intoxication when they show up to pick up their prescriptions at the pharmacy or at their doctor's office. And lastly, preoccupations with use or cravings can manifest as behaviors such as recurrent requests for opioid increase or complaints of increasing pain despite having no evidence of disease progression and despite titration of their prescriptions or prescription opioid doses already. Opioid use in cancer care presents a really interesting quandary. On one hand, opioids are effective, and we know that they are important medications for symptom management. On the other hand, we also have to acknowledge that there are significant harms, including addiction, overdose, and diversion. So knowledge about how to address this quandary is really the focus of the research that Lauren and I conduct together. So to close off that myth, we have a third polling question for you, which is, what factors increase a patient's risk for developing opioid use disorder? A, higher doses of opioids, B, longer duration of opioid therapy, C, A and B, or D, none of the above.
And some really nice participation. We'll just give it a few more seconds. All right, let's stop it here.
Excellent. So the majority of you chose A and B, which is correct. So you are paying attention, which is a good sign that you're not too hungry or sleepy yet right now.
Right.
Awesome. All right, so our closing myth is one that I am absolutely thrilled to be able to bust, because all pharmacy team members have a huge and impactful role to play when helping to prevent and manage opioid-related harms for the patients in their care. A recent ISMP report on medications most frequently cited in reports of harm incidents identified opioids in the top 3 medications contributing to harm incidences in all 4 healthcare settings studied, one of which is community pharmacy. This speaks to the large and important role pharmacy professionals can have, as many of us have established patient-facing practices in one of these settings. Any interaction we have with a patient experiencing cancer pain is an opportunity to support the patient's safe and effective opioid use. In 2017, in response to the increase in use and associated harms of opioids, national guidelines were developed to help guide and support clinicians in mitigating the risks associated with opioid use. These guidelines are specific to the use of opioids in chronic non-cancer pain, but as Jenny highlights, the risks of opioids are not related to the type of pain they're being used to treat, but are influenced by treatment and patient-specific factors such as opioid dose, duration of opioid use, the presence or absence of substance use histories, and risk factors for addiction. As advances in diagnosis and treatment of cancer improve, more people are living chronically with cancer and are using opioids chronically for cancer pain. So although the scope of these guidelines does not include patients with cancer pain, I strongly believe that patients in our practices experiencing cancer pain deserve access to the same and similar information, education, and supports with the goal of making their opioid use as safe as possible. Some examples of general practices and risk mitigation strategies suggested for management of opioids when used for patients living with chronic non-cancer pain are outlined in this table. Some additional risk mitigation practices that may enhance patient safety while using opioid therapy include gathering a patient's opioid use history from multiple sources and providing patient education on topics such as the role of opioids as part of a multimodal pain management strategy, opioid adverse effects, signs and symptoms of opioid-induced neurotoxicity and opioid toxicity, management of opioid toxicity, and safe storage and disposal of opioids. We know that opioids are effective for cancer pain management, and that opioids may be associated with harm incidences in a variety of care settings. We know, although not studied at this time in the cancer population, that there are risk mitigation strategies to enhance the safe use of opioids. One thing we do not know is, are we employing these strategies to support the patients in our practices who have cancer pain now? A recent study set out to answer this question. In 2020, an environmental scan was conducted to assess Canadian pharmacists' attitudes, confidences, and practices around managing and mitigating risks of opioids for patients receiving treatment for cancer pain. The primary objective of this project was to describe pharmacist opioid safety practices in the areas of assessment, management, and education. 25% of respondents were community pharmacists, and 11 were practicing in ambulatory care. A huge thank you to anyone who generously donated their time to this research initiative in the midst of the first wave of the COVID pandemic. For the assessment and management component of the primary objective, respondents were given a list of opioid risk mitigation strategies and asked to rate how often they performed these practices on a 5-point Likert scale. Statistical significance was not met for any of the results, which is likely due to our low response rate, but it's worth highlighting the amount of light green, which represents rarely or never. Most respondents rarely or never assessed storage and disposal practices or called other providers to gather information on a patient's opioid use history. This graph represents the education component of the primary objective. Respondents were given a list of patient education practices and were asked to rate on a 5-point Likert scale from never to always how often they provided patient education on these topics. This chart represents the percentage of pharmacists that reported always educating patients on these listed topics. As illustrated, we can see that overall, less than 50% of pharmacists identified as always providing education practices on these topics. I would like to encourage everyone to pick even just one of these topics to integrate into your practices on a routine basis for any patient on opioids. Opening this space for a conversation on one topic of opioid safety can have a huge positive impact on your patient's medication and pain experience. As an example, I would like to discuss the importance of educating our patients on safe storage and disposal of opioids. The 2019 World Health Organization guidelines specifically addressed safe storage and disposal of opioids within guiding principle 3, when they say, quote, provision of analgesia for cancer pain management can carry risks to the safety of patients, their families, and society more broadly. Consequently, proper and effective stewardship of opioid analgesics in the cancer treatment setting is essential to ensure the safety of patients and to reduce the risk of diversion of medicine into society. The presence of opioids in households presents a risk of misuse or unintentional opioid toxicity by children, adolescents, and other household members. Safe, secure storage of opioid analgesics should be optimized at the household level, and provision made for the safe disposal or return of unused opioid medicines to a pharmacy at the end of life or when no longer needed, end quote. A recently completed cross-sectional survey of 122 patients referred to Princess Margaret Cancer Center found that 52% of patients reported that they did not routinely dispose of their opioids. If these participants were to dispose of their opioids, 79% said they would do so by returning them to their pharmacy. The participants who did not routinely dispose of their opioids were more likely to report that they did not dispose of them in case they needed the medications in the future. The prevalence of patients identifying as disposing of unused opioids is higher in this cross-sectional survey than previous research in similar populations. In 2014, Reddy et al. Reported that 74% of adult patients with cancer receiving opioids in the outpatient setting were unaware of proper opioid disposal methods. 40% had unused opioids at home. 39% were unaware that opioids could be fatal. 26% reported unsafe use by sharing or losing their opioids, and only 8% reported disposing of their opioids by returning them to their physician or pharmacist. These results were replicated in 2017 when Silvestre reported that 7% of patients with cancer receiving opioids for at least 2 months who were surveyed in the emergency department disposed of pain medication by giving them to their doctor or pharmacist. The difference in results of these studies when compared to the cross-sectional survey may in part be explained by the impact of recent public awareness campaigns about opioids, their associated harms, and the importance of proper disposal. Educating patients on safe storage and disposal of medications, including opioids, is very much within the skill set of all pharmacy team members. And when conducted, it's seen to increase patients' likelihood to be aware of proper disposal methods for their opioids, to actually engage in these proper disposal methods by returning their unused opioids to the pharmacist, to conduct pill counts to increase awareness of the remaining supply, and to have knowledge of local drug take-back programs. There are many different ways to engage in impactful patient education practices. Some that have been studied and show statistically significantly positive results in increasing awareness of proper disposal practices and engagement with these practices includes providing patients or caregivers with an educational handout, reviewing the handout in a personalized education session, and conducting an opioid safety counseling session with patients on safe storage and disposal. Any time that you spend educating a patient or their caregivers on safe storage and disposal of opioids can increase understanding, information retention, and help address low disposal rates of opioids with the goal of reducing opioid-related harm for not just that patient, but also their loved ones and the community at large. ISMP has a really great one-page handout that I would encourage everyone to keep a few printouts of to be able to provide to your patients and have it included in any patient education packages that are standard in your pharmacies. You could also post it in your pharmacy at the drop-off and pickup counters, at the cash register, or any other relevant locations in your pharmacy to help encourage and remind our patients to engage in this simple safety practice and ask their pharmacy team for more information on local take-back programs. This would be a really impactful tool to include with and briefly review at each medication dispense. Returning to the Canadian Pharmacist Survey results on education practices, I want to next highlight the rate of education provided by pharmacists around naloxone. If you were not able to attend the recent education session hosted by Whole Health Group about naloxone dispensing and patient education, I highly recommend that you check it out. They did record it and it should be available to you either upon request or through the Whole Health team. It reviews the recently published Canadian naloxone guidelines, how to incorporate them into your practices. They compare and contrast the injection and nasal spray naloxone delivery systems and share insights around getting to know your local resources for supporting patients who require opioids for pain management. Of note, I was really thrilled to see that these guidelines do not subcategorize based on a patient's indication for opioid use or the etiology of their pain. To briefly recap the overarching messages of these guidelines, they recommend that naloxone, as an injection or nasal spray, be provided to every patient receiving a prescription for opioids, with the goal of reducing the risk of harmful outcomes related to opioid-induced respiratory depression. This patient care interaction is best provided using person-centered, destigmatizing language in a private setting, and the pharmacist should follow up with all patients after the initial education session at 3 and 12 months, and then annually as relevant. In addition to the comprehensive recommendations and guidance provided in the Canadian guidelines, we would like to recommend the following additional special considerations when counseling a patient with cancer on naloxone use as an opioid risk mitigation strategy. Firstly, inquire with the patient or their care provider what prior education they've received about the role of opioids in their cancer pain management strategy. Prior education provided about the role of, indication for, and associated risks of opioids in their management of cancer pain can vary greatly. When discussing the role of naloxone in their care, you may be telling the patient something they've not heard before or something that they were already told the opposite about. Secondly, some patients may refuse opioids for cancer pain management out of fear of harm. This can lead to patients experiencing a pain crisis, increasing their overall morbidity and potentially mortality, and reducing their quality of life significantly. One way to refocus the conversation if a patient or their care provider is endorsing opioidophobia is from the perspective of what we know about the efficacy of opioids in cancer pain, how adequate pain control can help them achieve their goals of care, and acknowledging that opioids are not without risk. It can be helpful to emphasize that one of our roles is to give the patient the tools and supports they need to ensure that they're as safe as possible while living with their cancer pain. Some of the tools that we can employ to support them include education about how to use opioids effectively and safely as part of a multimodal pain management strategy, following up with them at specific time points to see how they're doing, answering any questions they may have at any time and reviewing any information they might find helpful, educating them on how to safely store and dispose of their opioids, and to ensure they have timely access to naloxone and know how to use it should they or anyone in their family or community require it. When mentioning naloxone, the national guidelines recommend relating it to an EpiPen for public health safety. Lastly, the patient's goals of care and stage of disease are of critical importance to assess. If a patient is in their final days of life and receiving end-of-life care with the goal of passing away as comfortably as possible, the role of naloxone in that specific household would be to manage opioid-induced respiratory depression for other members of the household and not the patient themselves. A person's final stages of life to a non-healthcare provider may have a similar presentation to other causes of respiratory depression, including opioids. Patients at end of life are often receiving opioids for symptom control. And if a patient were to receive naloxone while passing away, it could be a very traumatic experience for both the patient and their loved ones, as it may lead to acute worsening of symptoms, directly contrary to the patient's goals of care. This is a very important factor to consider and use to inform your counseling points for this vulnerable patient population. As you may have noticed above, the patient and their care provider are both important persons in the patient's circle of care when assessing for opioid use history or risk factors and providing opioid-related education, including opioid use for effective pain management, as well as safety practices, including how to monitor for signs and symptoms of opioid toxicity, as well as if, how, and when to use naloxone. When analyzing the Canadian Pharmacy Survey responses relating to pharmacists' attitudes around risk of opioids in cancer pain setting, this study found that 86% of respondents disagreed that patients with cancer can become addicted to opioids. In reality, we know that there's published data stating that 1 in 5 patients with cancer may be at risk of opioid use disorder. And 83% of respondents disagreed that patients with cancer frequently take opioids as a means of chemical coping. It's been reported that approximately 1 in 5 patients with advanced cancer have used opioids as a means of chemical coping. Overall, pharmacists' attitudes tended to underestimate the risk of opioids in patients with cancer pain. This disparity between pharmacists' attitudes and described risk may be contributing to the low frequency of risk mitigation education practices that we saw above. It's important to acknowledge that no practice changes without its barriers. When respondents were asked to describe some of the perceived barriers to using community or hospital resources available for their patients, 3 themes emerged. The majority of responses were related to resources, which included the sub-themes of accessibility to and existence of resources, and the time to access these resources. The second barrier to using resources was education. Many respondents shared that they were unaware of resources available to themselves and their patients. Lastly, communication emerged as the third barrier. One respondent stated, "The hospital system is not linked to the community system, and it's hard for everyone to know what the other is doing. It's hard for patients to have seamless care." To directly address this respondent's comment, repetition is okay and likely beneficial, so I would encourage you to bridge this health system communication gap by going directly to the source, the patient and their care provider, and initiating a discussion around opioid safety practices at every opportunity. If it's a repetition, great. If it's new information, also great. It was inspiring to me to see that the perceived facilitators for this study lined up so closely with the aforementioned barriers. I hope that through busting this myth together today, some barriers have been removed to facilitate your uptake of opioid risk mitigation practices by increasing your awareness of existing tools, providing you access to some of these tools, sharing some ideas for implementing the existing tools into your practices and the practices of your colleagues within your teams, and engaging in educational opportunities such as this very Cancer Care in the Community webinar series. Some things that we can all do in our practices today or tomorrow, depending on where you are, to contribute to patients' safe and effective use of opioids to manage their cancer pain include, but aren't limited to, providing patient education around risk mitigation strategies and advocating for opioid stewardship programs to include services for patients with cancer pain. Also, it's important to include opioids in your assessment for deprescribing opportunities. So let's wrap this myth up with one final polling question. What can you educate patients and care providers about to promote safe opioid use? A, safe storage. B, safe disposal. C, effective use of breakthrough analgesia. D, naloxone use. or E, all of the above?
Just a minute, folks. I'm having some issues with launching this poll. Seems to be stuck here.
That's right. If people wanted to throw their response into the comments, that could work as well.
Yeah, definitely.
All right, I'm seeing some E's pop up. Thanks, Anna. Thanks, Kieran. And Lynn, this is very encouraging. I love the participation. Awesome. Great. Thanks, Jason.
E with an exclamation mark.
Yeah. Wonderful. Okay. You guys are hitting this one out of the park. The answer that we're hoping that you took from this myth busting fourth segment of our presentation is E. All of the above will make a huge difference to your patient's care. Whether it's one or any combination, it begins to open the conversation and make space to have informed discussion with patients as a standard of care around safe opioid use. So thank you all so much for your time tonight, and we truly appreciate the opportunity to join you today to bust these myths.
Okay, so to wrap that up as well, so I just wanted to thank Lauren and Jenny as well for coming this evening and presenting this amazing information. This presentation I found so intriguing, and especially busting those misconceptions that, you know, even ourselves as pharmacists may have still within our practice, right? I find that often, even myself and colleagues as well might feel a little bit intimidated when we're thinking about oncology, and especially around pain and oncology. I do see a question here that I'll pose with regards to opioid use disorder in patients who have cancer. Is there a different threshold that you may consider before kind of having that come up as a flag?
Yeah, so I'll take a shot at this, answering this question. So this is an area that is really interesting, and we're learning more around how to manage pain in the context of patients with cancer and patients with opioid use disorder. I think one important point to keep in mind is that spectrum of cancer care that I alluded to earlier. So management of a patient who is receiving curative intent cancer treatment, and if you suspect or you know that they have opioid use disorder, will be really different for management of a patient with cancer who has a history of opioid use disorder, who's at the end of their life. And so one of the big factors to keep in mind is that depending on where people are along that spectrum, they'll have very different goals of care. And you as a clinician will also have really different goals of care for that individual too. So for example, if we go back to the patient who is receiving curative intent treatment, then those patients, if you suspect that they have opioid use disorder, it's really important to keep a very close eye on them, to monitor them closely, to limit their opioid use, and if they are engaging in dangerous behaviors that put themselves or their family members or society as a whole at risk, then that's where it's really important to perhaps even stop dispensing them opioids, reaching out to their care providers so that they can connect with the patients and connect them with addictions medicine services. In contrast, if a patient is actively dying, they have a history of opioid use disorder, that's where the focus on quality of life is much more important. And so those strategies to still mitigate risk are really important. But in the end, symptom management, as long as you're trying to reduce harms and limit harms with the wider caregiver circle and society, will be even more important.
Thank you.
Yeah, and I'll say just one addition to that fantastic and comprehensive answer, Jenny, is I had the opportunity to speak to pharmacists in Atlantic Canada through Dalhousie Continuing Pharmacy Education back in the winter. And I had sent out a survey in advance of that presentation to ask about what are your experiences caring for patients in the community with cancer, and what are some burning questions you might have? What are some apprehensions you have? What's been your clinical exposure to this patient population, both from their anti-cancer therapy perspective as well as their cancer pain management perspective? And some of the anonymous comments that I got were really intriguing and shed some light on the conversation around what our thresholds should be in general for managing patients with cancer in the community, with a few related to, it's an opioid that was prescribed by an oncologist. So we just they have carte blanche and we know that they have the patient's best interest at heart. But the initial pilot study that was done prior to the National Pharmacist Survey was a single center survey among all healthcare providers, so oncologists, nurse practitioners, nurses, and pharmacists at a cancer center in Canada. And the results were not different than what we're seeing amongst pharmacists across the country. So oncologists are not reporting being more confident or having different attitudes or different practices around their assessment and prescribing of opioids for patients with cancer pain. So you're, as a pharmacist in the community, trust your spidey senses because this is a really new area and we're just starting to explore it now, and nobody necessarily has the answer. So we're all working through this together, and having those clarifying questions to the prescriber is a very relevant conversation to have if you do have any concerns or insights around patient safety with opioid use.
Amazing. Thank you both so much for that very well-rounded answer. I think it just highlights the fact that each patient would be unique, right? And again, bring up that fact of bringing up the individual patient goals to consider. And before we move on to the very last slide, this is just a reminder that this is session 2 of our Cancer Care in the Community series. We do have a session 3 as well coming up next month, and it will be on GCSF practical information for frontline pharmacists, also presented by an expert from Extend Pharmacy. So if you haven't already, please register for this. And my cat decides to jump into the screen right now. So September 16th at 7 p.m. as well. And the registration will be within the slides that you get at the end of the presentation. And as for the last slide, again, I said it already, but just want to reiterate how thankful we are to have hosted this with both of you with such a wealth of information in oncology practice. If anybody has any other questions, please feel free to add them on the chat or on the Q&A in the Zoom as well. And I'm sure Lauren and Jenny would be happy to stay on for 1 or 2 extra minutes to answer those as well. Please check out Extend Pharmacy online. And if you're interested in whole health, feel free to reach out at the email there as well. And thank you for that shout out earlier, Lauren, about our our Narcan webinar not too long ago. It's such a relevant topic these days, especially with all the challenges of the pandemic. And then, as you had noted on the slide as well, that International Opioid Awareness Day is just around the corner. So essential for pharmacists to be able to educate ourselves on this topic, educate our teams to be able to best support our patients.
Thank you so much for having us. It was really great to be able to speak about this topic that I know Jenny and I are both incredibly passionate about, and it's nice to see others are interested in it as well.
That's great. Thank you so much for inviting us.
Okay, thank you. So I think in the interest of time, maybe we'll end it there. If anybody has any extra questions, please feel free to reach out on the emails on the slide. And for the attendees, I will be sending out these slides soon, either this evening or early tomorrow for your access. And this event was recorded, so it'll be available on Whole Health social media, so both on our Facebook as well as our YouTube channel. Okay. Thank you, everyone. Have a great evening.
Have a good evening.